Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. New research has identified 5 specific exercises that reliably improve older adults' ability to climb and descend stairs, challenging the widespread assumption that stair difficulty is an unavoidable consequence of aging. Until recently, many training programs for older adults emphasized general strength as the primary remedy for mobility decline. However, converging evidence from clinic-based programs, lab studies, and observational cohorts indicates that a large portion of the functional loss observed during stair negotiation arises from deteriorating neuromuscular patterns and deficits in precise motor control rather than from a simple deficit in maximal muscle strength alone. Surveys and observational work have documented that many people over 60 experience difficulty or anxiety around stairs. In one representative survey, roughly 3/4 of respondents in this age group reported some stair-related difficulty. Within that same body of work, investigators noted a striking observation. Individuals who preserved effortless stair mobility into advanced age, some remaining comfortable on stairs well into their 70s, consistently retained 5 particular movement patterns that are frequently omitted from standard fitness routines. This evolving evidence base has shifted clinical practice and exercise prescription toward interventions that specifically retrain those patterns, movements that restore static holding capacity, isometric endurance, eccentric control, during descent lateral pelvic stability for single-leg support functional power, directed through the hips and knees, and ankle propulsive power plus endurance. When these targeted interventions are applied in real-world settings, clinical outcomes have been promising. For example, a large clinic-based program applying these principles to older patients reported marked improvements in stair confidence and function within 2 months without requiring specialized equipment. Lab-based observations that brief, focused daily practice could yield large gains attracted replication efforts in academic centers and clinics, supporting the view that retraining neuromuscular patterns, rather than focusing solely on maximal strength, provides a potent practical route to restoring stair function. The purpose of this revised report is practical to provide clinicians, therapists, and older adults with clear implementable guidance for rebuilding the neuromuscular patterns that underlie stair ascent and descent. The 5 exercises described below: wall sits, step downs, standing hip abductions, sit to stands, and heel raises with isometric holds were selected for their direct biomechanical relevance to stair tasks, their feasibility in most settings, and their capacity to be progressed safely. For each exercise, this document provides rationale, physiological background, detailed execution cues, progression strategies, common errors and corrections, and clinically relevant adaptations. The aim is not simply to prescribe movements, but to retrain coordinated control timing sequencing and endurance across repeated transitions. Those capacities are essential not only for stairs, but for a broad range of daily activities that support independent living. Clinical screening and safety considerations before beginning. Before starting any new exercise program, particularly in older adults, screening for cardiovascular, musculoskeletal, and neurological risk factors is prudent. An upfront safety review preserves participant safety and guides modifications for comorbidities, recent surgery, or sensory impairments. Basic safety recommendations include medical clearance individuals with unstable cardiovascular disease, uncontrolled hypertension, recent myocardial infarction, symptomatic arrhythmias, or acute orthopedic injuries should obtain clearance before progressing beyond gentle mobility practice. When in doubt, a primary care physician or cardiology clearance is reasonable prior to higher intensity or unilateral loading progressions. Balance and fall risk. Those with very limited balance, recent falls, or progressive neurological conditions should begin under supervision, physical therapist, exercise, physiologist, or trained clinician, and may require assistive devices during early training. Supervised sessions reduce anxiety, ensure correct technique, and enable graded exposure to challenging single-leg tasks. Joint disease. People with symptomatic osteoarthritis in knees or hips should use modifications, reduced range, slower progressions, and monitor pain closely. Transient delayed soreness is expected, but sharp or worsening pain requires reevaluation. Emphasize pain-free ranges and consider analgesic or activity timing strategies. Exercise when pain is minimal. Medication review. Beta blockers or other medications that blunt heart rate response may affect perceived exertion. Instruct participants to use perceived exertion scales, e.g., Borg scale, and monitor symptoms rather than relying solely on heart rate. Also, review medications that increase fall risk sedatives and coordinate with prescribing clinicians as needed. Footwear and environment. Use supportive non-slip shoes and perform exercises in clutter-free areas with a sturdy surface or handhold nearby. If home stairs are used for testing or practice, ensure adequate lighting, non-slip nosings, and accessible handrails. Simple baseline assessments help target intensity and track progress. Useful clinical measures include 30-second sit-to-stand test, number of stands in 30 seconds. Normative ranges vary by age and sex. A useful clinical benchmark is 15 stands in 30 seconds as an indicator of good lower limb functional power for many older adults. Timed stair ascent over a fixed number of steps, for example, time to climb 8 to 12 steps, or measured vertical distance. Record step height used and whether the handrail was used. Timed up and go, tug, rising from a chair, walking 3 meters, turning, returning, and sitting down. Single leg balance time, eyes open, measured to a comfortable maximum, commonly up to 30 seconds. Patient-reported measures perceived exertion when climbing stairs, handrail dependence, fear of falling, and stair confidence scales. These tests are low-cost, quick, and responsive to change with training. Record baseline measurements and reassess every 2 to 4 weeks to monitor adaptation and guide progression. 1. The wall sit building isometric endurance, purpose, and functional relevance. The wall sit develops isometric endurance, the capacity to sustain a static muscle contraction for extended periods. In stair climbing, repeated transitions often include brief static or near-static phases in which the quadriceps and gluteal musculature hold the knee and hip at a fixed angle while the body prepares for the next push. Improving the ability to hold that position resists fatigue, preserves alignment, and prevents the too-quick compensatory strategies that increase fall risk, such as rapid foot placement, over-reliance on handrails, or forward trunk collapse. Biomechanics and physiological rationale. The quadriceps group controls knee extension and acts as the primary anti-gravity support during weight-bearing phases of stair ascent. Isometric contractions involve force generation without a change in muscle length. They produce adaptations in muscle endurance, local metabolic tolerance, improved capillary density and oxidative enzyme activity, and motor unit recruitment strategies that differ from those produced by concentric or eccentric dynamic training. Because portions of the stair cycle require holding at mid-range joint angles, training the muscle at that joint position is highly specific and transferable. Isometric training also reinforces neural control of posture and co-contraction patterns that stabilize the knee and hip during static phases, particularly important for preventing knee buckling on transitions and managing step placement under fatigue. Detailed execution. 1. Position. Stand with your back flat against a sturdy vertical surface wall. Feet should be hip to shoulder width apart and squared forward. 2. Foot placement. Step both feet forward until your shins are roughly vertical. Forward distance depends on limb length and comfort. Typical spacing is about 2 feet from the wall for an average adult. Taller individuals may step slightly farther. 3. Descent. Slowly slide your back down the wall so the thighs approach parallel to the floor, creating about a 90-degree angle at the knees. For those with knee pain or limited range, a shallower angle, 100-110 degrees, is acceptable initially. 4. Weight distribution. Distribute weight through the heels and mid-foot rather than the toes. Press the lower back gently into the wall and engage the abdominal muscles to maintain a neutral lumbar position. 5. Upper body. Keep shoulders relaxed and breathe evenly. If hold duration is limited, allow rest as needed and return to the position for additional sets rather than forcing prolonged holds with poor alignment. Breathing and mental cues. Maintain rhythmic diaphragmatic breathing. Inhale for 2 seconds. Exhale for 2 seconds to stabilize intra-abdominal pressure and avoid Valsalva-like breath holding. Cue participants to breathe like talking steady and continuous, especially during longer holds. Common errors and corrective cues: knees drifting forward or caving inward valgus, slide the feet slightly back or widen stance. Cue to press the knees outward or squeeze a small ball between the knees lightly to engage lateral stabilizers. Excessive lumbar extension or arching, reduce the depth slightly and cue to tuck the pelvis and draw the belly button toward the spine. Ensure the back remains flush with the wall. Weight on the toes, shift weight back to heels. Holding breath, use audible cues to exhale rhythmically. Progression and adaptations. Beginners start with 20 to 30 second holds, 3 sets, with 60-90 seconds rest between sets. Emphasize technique over duration. Quality trumps time. Intermediate add 5 to 10 seconds per week as tolerated until reaching continuous 90-120 second holds. Once 90 seconds is comfortable, aim for 3 sets at that duration. Advanced introduce unilateral challenges, single heel lifts while maintaining the wall sit, or alternating heel lifts to increase unilateral control. Another advanced option is alternating brief marching motions while maintaining thigh position to simulate stepping transitions. Adding a small ball or light band between the knees to emphasize adductor co-activation can also increase stability demands. Programming guidance perform wall sits every other day to allow recovery of local muscular endurance. Frequency may be adjusted based on soreness and overall program load. Short daily touch-up holds 1 or 2 sets of 20-30s can reinforce the motor pattern without excessive fatigue. Clinical tips and expected adaptations. Over 4-8 weeks, participants typically report improved capacity to pause on steps, reduced shaking, and less need to immediately grasp handrails. Objective improvements include increased hold times and better perceived stability during step transitions. Improvements reflect both local muscular endurance gains and enhanced perception of stability, important for functional independence. 2. The step-down mastering eccentric control. Purpose and functional relevance. The step-down trains eccentric control, the ability of muscles to lengthen under tension while decelerating the body. Controlled eccentric strength is central to safe stair descent and to preventing abrupt collapses that lead to loss of balance and falls. Effective eccentric control improves energy absorption, reduces reliance on compensatory trunk motions, and supports controlled foot placement on lower steps. Biomechanics and physiological rationale. During step descent, the quadriceps eccentrically lengthen to absorb body weight and decelerate the center of mass as the foot contacts the lower surface. Eccentric contractions can produce higher force at lower metabolic cost, stimulate unique neural patterns, and lead to tendon and muscle tendon unit adaptations that increase resilience to loading. Age-related declines in eccentric control commonly manifest as heavy or uncontrolled step-downs, excessive handrail use, or rapid trunk flexion to shift the center of mass forward strategies that compromise stability and increase fall risk. Detailed execution. 1. Equipment. Use a low, stable platform such as the bottom stair, a 6 to 8-inch aerobic step, or a sturdy box. Ensure the riser is secure and non-slip. 2. Start position. Stand with both feet on the step edge. If needed for confidence, lightly touch a chair wall or rail, but avoid weight-bearing on the support. 3. Weight shift. Shift full or majority of weight onto the support leg and slightly bend that knee to prepare for the descent. 4. Controlled lowering. Slowly lower the opposite limb toward the floor over a controlled 3-second count, maintaining an upright torso and eyes forward. Avoid pulling the lowering leg with the upper body. 5. Touch and return. Allow the toes of the lowering foot to touch the floor lightly without transferring full weight, then press through the heel and center of the support leg to return to the step. Initially, return to the step with a 2-legged raise if necessary. 6. Repetition and side change. Repeat for prescribed repetitions, then change legs. Key execution tips: visual focus. Keep gaze forward at eye level to help maintain upright alignment. Tempo count out loud or use a metronome for consistent 3-second descents. Safety. Begin with low boxes and avoid high risers until eccentric control is established. Common errors and corrections. Rapid dropping. Slow cadence and coaching to lower like you have time is key. Slowing eccentric actions increases neuromuscular control. Knee valgus inward collapse. Use tactile feedback mirror or a light band above knees to train alignment. Perform short hip abductor activation drills, e.g. clams or side-lying hip raises before step-down practice. Overflexion of trunk cue to stand tall and to hinge slightly at hips with neutral spine. Weight transfer too early. Emphasize maintaining weight on the support leg until the lowering foot contacts the floor. Progression and program variables. Beginners 2 sets of 6-8 controlled step-downs per leg, 3x week, focusing on a 3-second lowering phase. Intermediate increase to 3 sets of 10-12 per leg after 2-3 weeks. Advanced add light external load-holding dumbbells or a weighted vest, increase step height gradually, or perform eccentric-only emphasis by lowering with 2 legs and raising with 1 to accentuate absorption capacity. Another advanced method is to lower slowly to a lower riser and step forward back to simulate real stair negotiation. Recovery and adaptation considerations. Eccentric work produces greater mechanical stress at the muscle fiber level and can cause delayed onset muscle soreness. DOMs, especially early in training. Plan for longer rest intervals between intense eccentric sessions, 48 to 72 hours initially, and advise gradual progression to limit soreness while preserving adaptation. Gradual ramping of volume and intensity helps tendon remodeling and reduces injury risk. Clinical notes. Eccentric capacity is highly specific. Practicing controlled step-downs transfers well to descent demands. Improvements often manifest in reduced handrail dependence and less brisk compensatory movements within 4-8 weeks. 3. The standing hip abduction, securing lateral stability. Purpose and functional relevance. Standing hip abduction strengthens the hip abductors, primarily gluteus medius, which stabilize the pelvis during single-leg stance. On stairs, single-leg support phases are frequent and challenging. Robust hip abductors prevent contralateral pelvic drop and inefficient compensatory patterns that increase energy cost and fall risk. Biomechanics and physiological rationale. During single-leg support, the hip abductors generate a counter moment to prevent contralateral pelvic descent. Weakness produces a Trendelenburg-like mechanism where the pelvis tilts and the trunk and lower limb adopt compensatory movements, e.g. lateral trunk lean, increased frontal plane knee stress. Targeted strengthening of the abductors improves frontal plane control, reduces compensatory trunk lean, and provides a stable base for effective concentric and eccentric actions at the knee and ankle during stair negotiation. Detailed execution. 1. Position. Stand beside a wall or sturdy chair for light support. Feet together or hip width apart. 2. Weight shift. Shift weight to the inside leg. Maintain a slight bend about 15-20 degrees in the support knee to absorb shock. 3. Movement. Keep the moving leg straight and neutral toes pointing forward, and lift it laterally, initiating motion from the hip rather than the torso. Avoid rotating the pelvis. 4. Range and cadence. Lift only to a height where tension is felt in the lateral hip, commonly 12 to 18 inches. Hold the peak contraction for 2 seconds, then lower with control over 2 to 3 seconds. 5. Repeating. Perform prescribed repetitions focusing on smooth, deliberate movement without momentum. Progressive cues and variations. Encourage, feel the muscle by placing a hand on the lateral hip to sense contraction. Use a mirror to monitor trunk position and pelvis level. For those with difficulty isolating the hip, start with side-lying hip abductions, non-weight-bearing, to provide tactile stability and proprioceptive input before standing progression. Common errors and corrections. Torso lean cue, to stand tall and engage core. Imagine balancing a book on your head. Light fingertip support to a chair is acceptable during early practice. Initiating from the lumbar spine, cue to initiate movement from the lateral hip and maintain neutral pelvis. Excess hip rotation. Keep toes pointing forward and avoid external rotation. Progression and programming. Beginners 2. Sets of 8 to 10 reps per side, slow and controlled. Intermediate, add a light resistance loop band around the ankles or just above the knees, and progress to 3 sets of 10 to 12 per side. Advanced, use heavier banding or small ankle weights. Incorporate single-leg balance challenges, eyes closed foam pad once sufficient strength and control are present. Combine with dynamic tasks, slow lateral step-ups to mimic real-world perturbations. Frequency and neuromuscular considerations. Pelvic stability benefits from frequent reinforcement, short daily practice sessions. 1 or 2 sets per day often outpace infrequent heavy sessions for motor learning and pattern retention. Frequent low-volume exposure trains coordination and timing that transfer directly to stair-related single-leg support demands. Clinical tips. Because abductor weakness is common after hip pain surgery or disuse, begin conservative and emphasize quality of movement. Pain-free activation and progressive loading facilitate tendon adaptation and reduce secondary compensatory patterns. 4. The sit-to-stand, rebuilding functional power. Purpose and functional relevance. The sit-to-stand trains coordinated hip and knee extension in a functionally specific pattern that maps closely to the demands of stair ascent. It develops the ability to produce force-quickly power, which is often more predictive of mobility and falls risk than maximal strength alone in older adults. Improvements in sit-to-stand power translate to quicker, safer stair climbing and improved ability to recover from perturbations. Biomechanics and physiological rationale. Kinematic and electromyographic analyses show that rising from a chair and climbing a step share similar timing and sequencing of muscular activation across the gluteal complex, quadriceps, and hamstrings. Power force produced in a short time interval is essential for propelling the center of mass upward. Age-related declines in type 2 muscle fiber size and neural drive reduce explosive force. However, repeated sit-to-stands executed with intent to move quickly while maintaining safety can partially restore functional power through neural adaptation and hypertrophic stimulus to fast motor units. Detailed execution. 1. Chair. Use a firm, stable chair that places knees near 90 degrees when seated. Avoid soft cushions that impede hip hinge mechanics. 2. Position. Sit near the front third of the seat with feet hip-width apart and slightly behind knees. This foot placement promotes effective forward trunk lean and heel-driven force. 3. Arm position. Cross arms over the chest to prevent using the upper limbs for momentum. Arms at side or lightly touching a lap are acceptable for those needing assistance. 4. Initiation and execution. Initiate by leaning the trunk forward so the nose moves over the toes, then drive forcefully through the heels to stand fully upright. Focus on explosive intent. During the concentric phase, stand as quickly as safely possible, but do not jump. 5. Lowering lower with control by hinging at the hips. Avoid plopping down. Use the eccentric phase to build strength and control by lowering over a controlled 2 to 3 second count. Progression and variations. Beginners, 3 sets of 8 repetitions with 60 seconds rest. Allow a slightly slower intent for those with pain or limited confidence. Intermediate progress to 10 to 12, then target 15 repetitions in 30 seconds as a functional benchmark. Power emphasis. Perform stands with an intent to stand rapidly while maintaining safety, not an explosive jump. Once competent, decrease chair height to lengthen range of motion or add a light weight held at the chest. Eccentric focus. Slowly lower to the chair over 3 seconds to emphasize control and strengthen the deceleration phase. Assessment and clinical benchmarks. The 30-second sit to stand and the time to complete a fixed number of repetitions are useful benchmarks. Achieving 15 sit to stands in 30 seconds correlates with minimal reported stair difficulty in observational samples. Progress can be objectively tracked and used to tailor intensity. Clinical cues to maximize transfer. Encourage heel drive. Cue press through the heels to maximize hip and knee extension torque. Trunk positioning. Advise a small forward lean to initiate momentum. Excessive trunk flexion may signal over-reliance on momentum rather than muscular power. 5. The heel. Raise with isometric hold, developing propulsive power. Purpose and functional relevance. Heel raises with an isometric hold target the calf complex gastrocnemius and soleus, which contribute substantially to propulsive force required for step ascent. Combining concentric rise and isometric peak hold and a controlled eccentric descent trains both power and endurance in the ankle plantar flexors critical for repeated stair ascent and for stabilizing the foot at toe-off during gait. Biomechanics and physiological rationale. The plantar flexors generate a large portion of propulsive power in normal gait and stair ascent. Age-related impairments often include reduced explosive force and shortened endurance in the calf muscle group, including an isometric hold at peak contraction, recruits motor units, differently preserves type 2 fibers, and improves the ability to produce and sustain force quickly. Full range of motion descent increases muscle tendon unit extensibility, improving ankle dorsiflexion range and elastic recoil that contributes to subsequent propulsive power. Detailed execution. 1. Setup. Stand with the balls of the feet on the edge of a stable step so the heels can hang freely. Lightly hold a railing or wall for balance. Do not rely on the arms for lifting. 2. Concentric phase. Rise slowly onto the toes to maximal height, focusing on a controlled, forceful elevation that emphasizes heel lift rather than hip motion. 3. Isometric hold. Hold the topmost position for 2 to 3 seconds to emphasize sustained firing at peak contraction. 4. Eccentric phase. Lower the heels slowly over 3 seconds until they drop slightly below the step edge, feeling a stretch in the calves. 5. Pause. Briefly, hold at the bottom for 1 second before repeating. Programming and progression. Weeks 1-2. Double leg heel raises 3 sets of 12 repetitions. Focus on full range and controlled holds. Weeks 3-4. Transition to 2 sets of 12 double leg raises plus 1 set of 6 single leg raises per side. Weeks 5+. Progress to 3 sets of single leg rises. 8 to 10 reps per leg, increasing hold time to 4 seconds as tolerated. Frequency. Perform these exercises several times per week, permitting at least 48 hours recovery between high-intensity unilateral sessions. Rest, 60-90 seconds between sets to maximize power recovery while maintaining training density. Implementation details and cues. Warm-up, execute heel, raises after a dynamic warm-up or other parts of the session to leverage neuromuscular recruitment in warmed muscles. Mental imagery. Visualize pushing the step away during the rise to increase neural drive. Imagery and brief mental rehearsal can augment motor unit recruitment and coordination. Foot position. Keep toes pointing forward and distribute weight evenly across the forefoot. Avoid excessive inversion or eversion. Integration into a coherent program, weekly structure, and phased progression. These 5 exercises are most effective when integrated into a cohesive program that respects individual capacity and allows gradual overload. Below is an 8-week phased example suitable for many older adults with basic mobility. Clinicians should modify intensity, volume, and frequency based on baseline fitness and medical status. Weeks 1-2 Foundation Neuromuscular Re-education and Tolerance. Wall sits 3 sets of 20-30s every other day. Step downs, 2 sets of 6-8 per leg 3x week with long rest days between sessions. Hip abductions, 2 sets of 10 per side daily or as frequently as possible. Sit to stands 3 sets of 8 every other day. Heel raises 3 sets of 12 double leg raises 3x week. Focus quality of movement, slow, eccentric control breathing pattern, and building routine adherence. Weeks 3-4. Capacity building, increased volume and slight overload. Wall sits. Progress to 3 sets of 45-60s every other day. Step downs, 3 sets of 8-10 per leg 3x week. Maintain 3-second lowering. Hip abductions, 3 sets of 10-12 per side daily. Add a light band if comfortable. Sit to stands. 3 sets of 10 to 12 every other day. Begin to increase speed with control for power emphasis. Heel raises 2 sets of 12 double leg. 1 set of 6 to 8 single leg 3x week. Focus build endurance, introduce asymmetry and unilateral control. Weeks 5-8. Power and specificity, higher intensity, unilateral emphasis. Wall sits 2 to 3 sets of 90s, or introduce heel lifts within the wall sit for unilateral demand. Step downs, 3 sets of 10-12 per leg. Consider modest external load or higher step only when technique is secure. Hip abductions, 3 sets of 12-15 with progressively heavier band. Include balance challenges, foam pad eyes closed as tolerated. Sit to stands, target 15 reps in 30s, or add lower chair, or lightweight if 15 reps achieved easily. Introduce brief fast sets, 5-8. Explosive repetition sets separated by longer rest for power development. Heel raises 3 sets of single leg rises, 8 to 10 per leg with 3-4s hold 2 to 3x week. Focus transfer to stair-like tasks. Supplement with actual stair rehearsal under safe conditions, slow controlled ascents and descents with available handrail. Micro sessions and daily touch-ups. For adherence and motor learning, short daily micro sessions are useful. A 10-minute session could consist of 1 set of wall sit 30s, 6 step downs per leg, single set, 10 hip abductions per side band if available, 1 set of 10 sit to stands or 15 seconds of fast sit to stands, 1 set of double leg heel raises 12 reps. These brief practices reinforce patterns without producing excessive fatigue and are especially useful on days when longer sessions are missed. Monitoring progress and outcome measures. Track functional progress using simple, repeatable tests at baseline and every 2 to 4 weeks, 30-second sit-to-stand number completed. Timed stair ascent over a fixed number of steps or measured vertical distance record step height and whether handrail was used. Single leg balance time. Eyes open, measured up to 30 seconds. Timed up and go tug. Patient-reported outcomes, perceived exertion when climbing stairs, 0-10 scale handrail dependence confidence scales, and fall incidents. Clinicians should document technique quality as well as quantitative measures. Small improvements in alignment, reduced trunk compensations, and reduced handrail reliance often precede large changes in timed performance. Expectations and typical timelines. Most people report subjective improvements in stair confidence and reduced perceived effort within 4 to 8 weeks of consistent practice. Objective improvements in timed stair ascent, sit-to-stand counts, and single-leg balance are commonly measurable within this interval. Faster gains may be seen in motivated individuals practicing daily, whereas those with significant comorbidities or persistent joint pain may progress more gradually. Expect early neural adaptations, improved coordination and timing in the first 2 to 4 weeks, and measurable strength and endurance adaptations from weeks 4 to 8 onward. Modifications for common clinical scenarios. Knee osteoarthritis. Reduce range of motion, initially avoid deep knee angles, prioritize eccentric control and pain-free loading, and progress slowly. Use a chair with arms initially for sit-to-stand if necessary, and limit step-down height. Anti-inflammatory strategies and weight management may support progression. Balance impairment. Begin with bilateral variations and close hand support. Use fingertip or light contact handrail support, early progressing to unsupported movement as balance improves. Parallel bars, harness systems, or supervised sessions are appropriate for very high fall risk. Hip replacement or severe hip pathology. Coordinate with surgeon, therapist for weight-bearing precautions and safe ranges early after surgery. Begin with seated or supine hip activation drills and delay high-demand unilateral tasks until cleared. Stroke or neurological impairment. Emphasize repetition, slow cadence, external cueing, and sensory feedback. Bilateral and assisted versions help re-establish motor patterns before unilateral progression. Consider constraint-induced principles, more repetitions on the affected side to promote neuroplasticity. SHU, peripheral neuropathy or sensory loss. Increase reliance on visual and proprioceptive strategies, reduce unstable surfaces early, and use tactile cues and supportive footwear. Balance training should be progressed conservatively. Adherence strategies and behavioral supports. Sustained practice is critical to durable change. Simple adherence strategies include scheduling. Encourage exercising at the same time each day to build habit. Linking exercise to established routines, e.g., after morning medication, improves adherence. Short sessions. If fatigue or time constraints limit practice, shorter daily sessions, 2, 5 to 10-minute blocks often yield better adherence than longer, irregular sessions. Record keeping. Maintain a simple log of sets, repetitions, and subjective difficulty to track gains and reinforce effort. Environmental cues. Place a resistance band near a chair, mark a step in the home, or keep a small weight visible to reduce barriers to starting. Social support group classes, partner training, or community programs increase accountability and enjoyment. Positive reinforcement celebrates small milestones, e.g., reducing handrail use on a short climb to sustain motivation. Troubleshooting common problems. Excessive soreness. Reduce volume or cadence, increase recovery days, and ensure adequate warm-up. Consider decreasing eccentric emphasis temporarily and gradually ramp back up. Persistent joint pain during an exercise, reassess technique and joint alignment. Substitute a lower impact variation, e.g., partial range heel, raises reduced depth, sit to stand, and consult a clinician if pain persists beyond 72 hours or is accompanied by swelling. Plateau in progress. Vary the training stimulus, e.g., brief power emphasis in sit to stands, altering band resistance for hip abductions, reassess baseline measures, and confirm adherence consistency before increasing intensity. Anxiety about stairs. Incorporate graded exposure, start with one step and slowly increase complexity while practicing newly learned movement patterns. Combine with breathing and relaxation techniques to reduce fear. Clinical vignettes, illustrative examples. Mrs. A, 72, mild knee OA, began the foundational program with reduced wall sit depth and partial range step-downs. By week 6, she could climb 3 flights without using a handrail and reported a 50% reduction in perceived effort during family visits. Objective measures sit to stand increased from 9 to 14 in 30 seconds. Single leg balance improved from 6s to 16s. Mr. B, 68, post-knee replacement 6 months. With surgeon and therapist clearance, progressed from double leg heel raises to single leg versions. Over 10 weeks, he improved single-leg balance time from 5s to 20s and transitioned from descending stairs with a caregiver to descending independently with reduced fear. Ms. C80 balance impairment and neuropathy. Started with seated hip abductions and partial sit-to-stand transfers, progressed to standing hip abductions with light support, and then to low step-downs. Over 12 weeks, she reported reduced handrail reliance and increased confidence walking in community settings. Limitations, research gaps, and future directions. While clinical programs and replication studies demonstrate meaningful gains from targeted pattern training, several questions remain. Optimal dosing for different subgroups. The most effective frequencies, durations, and intensities for frail older adults. Those with advanced osteoarthritis or those with cognitive impairment need further clarification. Long-term retention. How well these neuromuscular pattern gains persist without ongoing practice is not fully clarified. Maintenance strategies and minimal effective dose for retention merit study. Relative contribution of each exercise. Although the 5-exercise package is synergistic, determining the independent contribution of each component and whether fewer exercises could produce similar outcomes would help streamline practice. Technology integration, investigating biofeedback, wearable sensors, and telehealth-guided programs to enhance motor learning and adherence is a promising area. Broader population trials, larger randomized controlled trials comparing pattern-focused programs with conventional strength-only regimens across diverse populations, rural various cultural contexts, differing comorbidity burdens would clarify best practice recommendations. Conclusion: a synergistic practical program to restore stair mobility. The 5 exercises described, wall sit, step down, standing, hip abductions, sit to stands, and heel raises, with isometric holds constitute a coherent synergistic program that targets the principal physiological components required for confident, efficient stair negotiation. Each exercise addresses a distinct but complementary element, isometric endurance, to sustain supportive positions, eccentric control, to manage descent safely, lateral stability, to maintain pelvic alignment during single leg support, functional power to generate upward force quickly, and ankle propulsive capacity with endurance for repeated steps. Taken together, these movements retrain neuromuscular patterns rather than merely increasing isolated maximum strength. Clinically, programs grounded in these principles have produced rapid and meaningful improvements. Large clinical cohorts report high percentages of patients experiencing easier stair use within 8 weeks, and controlled trials have documented substantial gains in stair speed, perceived effort balance, and functional independence when targeted patterns are trained systematically. For practical implementation, clinicians and older adults can assemble the exercises into routines that reflect current capacity and progress gradually. A representative weekly plan pairs higher load, less frequent sessions, e.g. step-downs, single-leg heel raises, with daily low-volume pattern reinforcement hip abductions, short wall-sit holds. Attention to proper form, moderation of initial volume, gradual progression, and consistency are crucial for safety and success. Individuals with significant joint disease, severe balance impairments, cardiovascular concerns, or other medical issues should consult a healthcare professional before beginning. Exercises can generally be modified, shorter holds, reduced range of motion, added support for balance to accommodate limitations while still training the key neuromuscular patterns. In sum, the evidence supports a shift from generic strength training toward targeted pattern-focused practice to restore stair climbing ability in older adults. By systematically training isometric endurance, eccentric control, lateral pelvic stability, functional power, and ankle propulsive capacity, older adults can regain confidence and competence on stairs, preserve independence, and broaden opportunities for active living. With careful screening, consistent practice, and progressive overload matched to individual tolerance, these exercises offer a practical, low-cost, and scalable approach to a common and consequential mobility problem. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together, we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement. Every day you choose to move, your body responds with strength, balance, and renewed life. Each gentle motion is a gift to yourself, calm, mindful, and full of vitality. Together we move, we heal, and we thrive. Keep the rhythm of your golden years. Nurture health, cherish every movement.